because those behaviors will continue to push on motor units. And those behaviors will cause people to guard the jaw, for example, in order to protect painful areas at the expense of now overusing other areas within the muscle in order to ultimately maintain the targeted behavior of speaking and eating. And so these behaviors are extremely insidious at times in terms of the subtlety with respect to how guarding of the mandible can take place. And guarding refers simply to holding the jaw in a rigid position in order to protect it from movement that the individual knows will then cause pain. And guarding can occur with the teeth separated, guarding can occur with the teeth lightly in touch, guarding can occur with the teeth firmly in contact, either in the maximum occlusal position or in some type of excursive position. People will do all of it. People will forcibly put their tongue between the teeth, again, as a form of guarding, once they've developed a pain problem and once muscles in particular have become dysfunctional. And this is where behavior then becomes a key link in understanding how pain moves from an acute pain disorder and then transitions into a chronic pain, because people want to continue to function. And so this model then stipulates that behavior then does in fact lead to pain, and which in fact then does lead into the same behavior, but with different recruitment of the motor units in order to allow the function, let's say chewing, to actually occur. And so motivation and intention underlying behavior is a critical piece then in understanding the role of parafunctional behavioral patterns and their how those behavioral patterns can perpetuate pain problems in that part of the body. And what we know about the jaw is simply building on what has been studied for decades with respect to the back and the hip structures with respect to lower back pain. So in terms of jaw behavior then in TMD pain, on the one hand, I'll read to you, widespread beliefs link sleep bruxism and occlusion with pain, and therefore the rationale for an amazing range of oral appliances. And similarly, there have been widespread beliefs linking waking jaw behaviors with pain, and the vicious cycle theory was the purported link for that. The data, however, have been somewhat limited, supporting either belief regarding the role of sleep bruxism in pain and the role of waking behaviors in pain. We've got some good theoretical models at this point. We understand the neurophysiology, but the clinical evidence is still developing. And consequently, the assessment of jaw behavior is not in either axis 1 or axis 2 of the DCTMD. What we do assess, however, is the person's report around parafunctional behaviors as a way to begin to understand the models, the potential neurophysiology that's underlying what a person is doing and how that may be contributing to their pain. So here's a summary on sleep bruxism and pain, and then I'll just show you a little bit of data. But this is the big picture. And I provide the citations here, the evidence where that is. But everyone exhibits sleep bruxism at least a little bit of the time. Everyone. So sleep bruxism is a continuum, from a little to a lot. And the typography, the structure of sleep bruxism in the moderate to severe bruxers varies. Most severe bruxers typically have no pain. And so if bruxism is bad, then more bruxism should have more pain. But the most severe bruxers, those with clearly and severely worn teeth, are typically pain-free. And that's one of our clues regarding the complexity of how we think about these behaviors and development and maintenance of pain. Bruxism episodes are triggered by microarousals. They are not triggered by occlusal interferences. So occlusion should not be adjusted or altered in order to, as a putative treatment for sleep bruxism. The existing literature highly now questions the relationship of bruxism and pain. And whereas longitudinal studies do support a relationship between sleep bruxism and pain. And so right now we are in a dark space with respect to our understanding and knowledge. And then finally, cross-sectional sleep lab studies, polysomnography, PSG, provide no support for bruxism as a cause of pain. So here's some evidence. On the left, a study by Gallo, 21 people in Zurich, Switzerland were identified who were extremely healthy. They screened thousands of people to find these 21. And in these 21 people, for the vast majority of most of the sleeping period, there's no bruxism going on, as evidenced by the bar here over 0. But then you can see this decreasing line of bars extending out to 30 or more seconds of durations of bruxism found during sleep. And then this is just simply the cumulative plot back up to 100% as shown over on this axis. So in very healthy people, the majority of the time, there's no sleep bruxism, but yet 50% of the time, there is 1 second or more going on. Over on the right, a similar kind of study comparing controls, people who were believed by the investigators to not engage in sleep bruxism and people who were believed by the investigators to engage in sleep bruxism based on clinical criteria. And the distribution in the open bars is exactly like what you see on the left-hand side, and then notice the overlap in the black bars of the people who are grinding their teeth at night. RMMA stands for rhythmic masturbatory muscle activity, just another phrase for what is happening during sleep. Here are two plots from different researchers looking at controls on the left and nocturnal bruxers on the right. Nights are plotted on this axis, the number of minutes through the night, 6 hours, plotted on this axis, and then the severity of what is measured on the vertical axis here. And you can see that there's a mean of 7.4 seconds per hour in this control group, and you can see the topography of this through the sleep phases at night across nights. It's highly scattered, highly inconsistent. If you contrast that with the bruxers over on the right-hand side with a mean of 27 seconds per hour, and every night is filled more or less the majority of the time with sleep bruxism episodes. And then finally, an N of 1 study following somebody for 6 months who wore a monitor every night, reported their stress levels on a 0 to 8 scale and their pain levels on a 0 to 8 scale. And you see by and large correspondence with higher pain, particular stressors that are identified here, quarrel with boyfriend, an exam, etc., and then correspondingly an increase in what's happening during sleep. And then over here with 4 more people, also similarly monitored here for about 40 days or so, identifying episodes associated with increased activity of the muscles during sleep. And so we have this quandary then in terms of, well, does sleep bruxism, is it responsive to stress? Well, in some people, yes, but not in everybody. Does it cause pain? In some people, yes, but not in everybody. The mechanism underlying this, as I'd mentioned before, is sleep microarousals, which then lead to an activation of the cortical structures and the autonomic cardiac system. That then leads into activation of the motor neurons. So this happens first, and then the motor neurons are activated for the rhythmic masturbatory muscle activity, which is then what we call sleep bruxism, which is then characterized by an increase in jaw muscle activity, and an increased probability in tooth contact and grinding during sleep. Characteristics of sleep parafunction. There's on the temporal side, as I showed you, episodes are highly variable. We contrasted in a slide 2 slides ago controls versus serious bruxers, and for everybody, episodes are highly variable, which might be across days or weeks. 2 sounds occur only in about 30% of episodes, so it's not a very sensitive indicator whether a person is grinding at night. And then in terms of the what actually happens during sleep, there's actually two different kinds of activities that happens. There's the grinding, which is phasic, shown by bursts here, and then there's the tonic, which is clenching, which is just a sustained activity within the muscle, and that's what's shown here as muscle activity. Patients typically will seek treatment because tooth sounds, meaning the tooth partner says you're making these noises during sleep, or because the patient has noticed that the teeth are wearing more than they think they should, because of orofacial pain, and then sometimes because of tooth hypersensitivity is the complaint, not because the person believes that they are grinding, but rather because the teeth are sensitive. Chairside diagnosis for tooth grinding, more often than not, it is a family or bed partner complaint because of the noise. Obviously, if the person sleeps alone, you won't have a partner complaint, or if the person is a dentulous and takes out the dentures at night. As I mentioned, the occurrence is highly variable over time. Sounds of tooth grinding can be confounded by other kinds of sounds that happen during sleep, such as snoring, noises in the jaw joint, or other noises. Life stress as a proximal trigger is only one possible indicator. The clinical symptoms, on the other hand, typically are much more useful as from a diagnostic level. Mascatory muscle pain or fatigue is present on awakening, and that typically resolves in 1 to 2 hours if waking parafunctional behaviors are absent, and often there is headache associated with the pain, which can also occur in the form of jaw locking. Tooth hypersensitivity is a useful indicator if multiple teeth are involved, but that can be confounded by other potential causes for tooth hypersensitivity. Tooth wear is not a very good indicator because it's not correlated with the extent of behavior. It may indicate past episodes that are no longer present. It can be the tooth wear from bruxism can be easily confused with tooth wear that occurs from dietary factors. Dental casts have been regarded as the best way to measure whether tooth wear is of the form related to bruxism in the sense of sharp, clean facets. Calibration is essential, however, for examiners because uncalibrated in terms of detection of tooth wear, dentists are remarkably unreliable in the detection of this, as shown on the bottom, particularly for posterior teeth. We do better with anterior teeth, but calibration is essential, and even then, it's still not very good. So I would never make a diagnosis of sleep bruxism based solely on the presence of tooth wear. Other findings, master muscle hyperactivity, but that can be caused by oral parafunctions in general, and then muscle hyperactivity has to be distinguished from hard diet or parotid swelling. And then there's miscellaneous conditions that can create a suspicion of sleep bruxism. One of the most common that most dentists will typically encounter somewhere in their career is a patient who comes in with serial failures of and fractures of teeth or restorations. It's like month by month, there's a new tooth that's broken, and that will typically be an indicator that there is a common cause then for each of these tooth fractures. And then occlusal trauma, pulpitis, and condylar changes can also contribute to this. These other changes, however, are not specific to bruxism, and other conditions should obviously be investigated. So in short, the diagnosis of sleep bruxism requires a lot of reasoning skills. There is no one indicator for it, and it's easy to overdiagnose. And it's certainly very, very easy to overtreat sleep bruxism that may be in the normal range. And we don't know what that is. If there's consequences from it, then yes, you should intervene. The suggested clinical criteria, recent history of tooth grinding sounds, as indicated, morning mascatory muscle pain. for about 2 hours that then resolves or reduces and is clearly distinguished from other pain. Presence of current tooth wear, however, as I mentioned, we are not so reliable in that assessment. And then masseter muscle hypertrophy, thank you, detected via voluntary clenching. And again, we still have a very similar problem of examiner reliability because this is not a hard finding. But these are the suggested clinical criteria at this point in time. Sleep bruxism occurs in types. This is not for you to memorize for testing purposes, but rather just simply to recognize that there's the primary idiopathic, which is the most common, but then it can also occur as secondary to other kinds of conditions. And then it can also be iatrogenic in relation to caffeine, which is a particularly strong cause for people to brux during the night, caffeine taken later in the day, and then a particular class of medications for depression of the SSRIs. And then there's other causes of secondary and iatrogenic bruxism. I list them here just simply for completeness, just simply to highlight that what looks like a simple thing, a person grinding their teeth at night, can be anything but simple. So, does sleep bruxism cause pain? No and yes. We really don't know. Careful history and follow-up over time and very careful titration of treatment is obviously what a careful clinician would do. Waking parafunctional behaviors, in contrast, used to be something that we knew very little about compared to sleep bruxism. And at this point, I would say that we know more about waking parafunctional behaviors in their relationship to pain and more certainty about that than we have with regard to sleep bruxism. So I'll talk briefly about life course, measurement and classification, and relationship to pain, and then we will conclude for the day. And I'm noticing where I am in the time, so I may have to skip some slides here. So this is a very important slide here because it illustrates three things. One is that there's a variety of behaviors that people report as their dominant behavior. The prevalence of those behaviors depends on the age of the person. So for example, young people do bite objects far more commonly than people 25 and older. And some behaviors are fairly consistent throughout life, such as pressing the tongue. And then other behaviors, such as clenching or grinding, have an increase and then a decrease. And this reported increase and decrease in the prevalence of clenching grinding seems to follow the prevalence of TMD as well. Just a side note. In a similar study, also done in Sweden as the prior one, what's shown here is that 400 children, ages 7 and 11 and 15 enrollment, were followed at 20 years. And the dominant behavior reported at enrollment was also the same dominant behavior reported 20 years later. Again, consistent with the prior slide, that what we do at an early age is what we tend to do later on in life as the dominant behavior. What I want to highlight, however, is that a dominant behavior doesn't mean that there are not other behaviors present as well. And typically in the person who has a painful TM disorder, they report multiple different types of parafunctions, not just simply one as the dominant alone. As I mentioned in the prior lecture, the use of a paper instrument like this is dramatically superior to just simply asking in an interview whether the person clenches or grinds or does any of this kind of stuff during the daytime. And it's because completion of a paper instrument prompts introspection by the individual, and that self-awareness that can change from completing this form prior to doing a clinical interview saves so much time and effort in the clinical interview in order to identify something that we believe is very, very important. Here is a simple study that we did some years ago. People were just recruited very simply 20 cases with TMD and then 20 controls who did not meet criteria for TMD at that time. And then on the items that were assessed, you can see the dramatic differences in each of these behaviors that are reported on that same paper instrument that I just showed you. Here is single subject data where the red bars represent what's happening with muscle activity as the person is asked to do each of these behaviors. And then the numbers match the frequency up here of how often the person is doing each of these behaviors. And so you can see a complex interaction here between magnitude of force associated with a given behavior and how often that behavior is actually executed during the week. And so is a lower pressure, a lower magnitude force as measured by muscle activity for clenching that's done most of the time, is that more or less severe as a contributor than, say, holding or biting objects, which has much more muscle activity attached to it, but which is done less often? I don't know the answer to that. I don't know that anyone knows. Instead, we think of this as a mosaic of lots of behaviors, and that each one surely has varying levels of muscle activity, and clinically we just need to mix it all together in our heads. Here is some data demonstrating that the targeted behaviors, as shown on the bottom of the slide, are associated with differing patterns of how muscles are recruited to engage in that behavior. And so think back to what I described earlier with the adaptive behavior model of how different motor units within the jaw muscles are recruited in order to execute different behaviors. Surely that is part of the uniqueness that's associated with each of these behaviors having differing kinds of vectors from the differing contributions from the muscles that act in different directions. So in short, the jaw has, four major muscles that move the jaw, right? The medial outer pterygoid, temporalis, and masseter. And then there's suprahyoid group. And people are multi-talented in all the different ways that those muscles can be recruited to create just an amazing, complex patterns that are unique to each individual. Here are some data showing that, as I described, that these behaviors are typically unconscious. So what we see on the y-axis is what is the proportion of time that the person is reporting those behaviors by using an active monitoring device throughout the daytime. And so, you get a total number of behaviors or total number of report periods, and then what's the proportion of those report periods that each behavior has been reported. And then on the y-axis, we see the paper form, the paper instrument that we like to actually use. And, remarkably, a very strong linear relationship between what people report if you do it out in the field with something that's monitoring multiple times during the day. Right now, are you clenching? Right now, are you touching or holding, etc.? And then what a person is asked to do on a paper instrument. So the paper instrument has been a huge game changer, such that when we administer this instrument in people who have chronic painful TMD, and then score the instrument at, say, a 25 or more, which is, add up the scores, 0 to 4 on all the items, for people who are scoring 25 or more, who have chronic TMD, the odds are 17 associated with having chronic TMD and that score. Now, an odds of 17 for a simple variable like this is an extremely high number, and we don't believe that that is reflecting pure causation. Rather, we believe that that is reflecting a reciprocal path between pain and behavior, and then back to pain and back to behavior. If we administer this instrument to people who've never had TMD in their life and then follow them every 3 months, and then some of them will report the development of a painful TMD, those who reported a score of 25 or more were almost 2 times more likely to develop TMD compared to people who were reporting a score down here of a very low score of 0 to 16. Demonstrating that these behaviors do have a very strong role in causation, and they have an even stronger role than in facilitating maintenance of pain into chronicity. 2 experimental studies were done looking at this issue of occlusal interferences, just because dentists still have the belief that occlusion matters. And the first study was done with individuals without TMD. The second one was done in individuals with TMD. Occlusal interference was either placed in a non-functional area, as shown here, or it was placed in a functional area on the tooth, as shown here in the drawing. And people were crossed over in the study, so people were either in the sham interference group first, followed by active interference, or reverse, and this was true for both of the studies. And so if you look on the left for those who don't have TMD, what happens during the active interference is that muscle activity during sleep drops compared to the placebo condition or the pre and post experimental periods. If we look at people who have chronic painful TMD, the active intervention, active occlusal interference, results in an increase in muscle activity. And so the occlusion hypothesis is partially correct in that, yeah, something is happening, but it is not the full answer, because in normal individuals, it acts in an inhibitory kind of way. And so how do we put these 2 pieces together? Well, the model is now one of occlusal hypervigilance, people paying excessive attention to the occlusion, that is far more important than the characteristics of the occlusion itself. And then there is the impact of situational stress that then activates these behaviors, as well as hypervigilance toward the occlusion, and that people adapt differently to the occlusal changes and to stress in terms of the role by which these behaviors, as mediated by potential occlusal contact of the behaviors, in terms of who's going to develop symptoms or not. And so with this slide is the conclusions. Sleep bruxism has a complex relationship to pain and is as yet not well understood. It's a far simpler problem than waking parafunction, but it seems like it's a more complex one. Waking parafunction comprises behaviors that have clearly understood terms. They are readily measured via self-report, and they can result in pain. Adaptive behavioral models provide support for learning, whereby new parafunctional behaviors emerge as a respondent behavior. What we do not know about waking parafunction is the overall significance of force vectors and the associated disorders. As I've mentioned, the jaw is an incredibly complex structure, and what people do with it is equally complex. We don't know how the behaviors themselves actually result in pain. What is the proximal mechanism of nociception, for example? And we don't really know what the most effective treatments are. We have some idea, but we also know that those treatments are not as successful as quickly as we'd like to see. In terms of treatment, oral appliances should not be used to treat sleep bruxism until the patient's full history is understood, and oral appliances should, in general, not be relied upon to treat waking parafunction, which is to say that there is not an occlusal dominant focus in waking parafunction. Think back to the prior slide with the role of occlusal hypervigilance as being a profoundly more important factor than occlusion per se. And I'm going to skip this slide. And in fact, this is the end of the lecture, and I forgot to just put a end of slide. End of lecture slide here in my slide pack, but your slide packs should end at this point. And with that, I will stop and Dr. Gonzalez, do you get questions from the students at all?
I don't see any in the chat.
Okay. So I will stop screen share here.
But people have the opportunity to unmute and ask a question directly if they would like to. I just want to add, Richard, that even though you clearly explained that the oral behavior and the job functional skills are not in the screening column.
Brief screen.
Yeah, for the brief screening. When the pre-doctor students come with their patients, they actually complete both forms in our clinic when they work with us.
Okay, good. So you're using the screen level as published by the DCTMD.
Plus.
And the ultra. I'm sorry.
Plus the
Yeah. No. That's what's published in the DCTMD. The ultra brief has come because practitioners have said, well, that's still just too long. And so we have thought about, well, how can we make it even shorter and still capture the major dimensions? And so, what I presented was an oversimplification of those 3 levels of screening, and thank you for correcting that.
I don't see any questions, so it's 11:51. So I want to thank Dr. Orbach for his time and his expertise, and we will see him next week again. Thank you so much.
Bye-bye.
Bye-bye.